Dear PWNs, let me discuss some questions, previous year questions that were asked in our INICET. Okay, let me start my session. In neonatal, the first question, in neonatal resuscitation, which of the following is the most effective indicator of successful ventilatory effort? Is it color change, rise in heart rate, air entry, or chest rise? Whenever we do good intubation, definitely air entry will be bilaterally equal. Your chest will be rising. Your heart rate will increase because your hypoxia will decrease. The most common manifestation of hypoxia is bradycardia. So whenever you do ventilation, bradycardia will be converted into normal heart rate or tachycardia, which indicates that the way you are doing your resuscitation is normal. And finally, if the child color is blue or a cyanotic, the color will be changed. Whenever you look this question as a whole, it seems that each and every option is correct. But the most important factor in case for successful neonatal resuscitation is increase in heart rate. Is your increase in heart rate. Is your increase in heart rate. The answer for this question is increase in heart rate. There are certain things that we need to discuss in this question. Or when do you, so what are all the three most things that we see? What are all the three most things that we see in resuscitation? So one is classல இருக்க phone வைங்க. classல இருக்க phone வைங்க. Okay, what are all the three most things that we see in case of resuscitation? So one is whenever the child is born, your resuscitation is mainly based on, first one is what? Turn of the baby. Second one is whether the baby is crying or not. Third one is, so first one is tone, second one is cry. So what else you will see? You will not see abgar. You will not see color. The three things that you will see is tone, cry, as well as whether the child is term or preterm. So these are all the things we give importance for neonatal resuscitation. These are all the things we don't give any importance. As far as the resuscitation is concerned, what are all the things we need to see? One, when the heart rate is more than 100 per minute, there is no need for any positive pressure ventilation. Your child is said to be normal. When the heart rate is more than 100 per minute, the child is said to be normal. There is no need for any positive pressure ventilation. If the heart rate is less than 100 per minute, if the neonatal heart rate is less than 100 per minute, you start your positive pressure ventilation. In case of term baby, in case of preterm baby. In case of term baby, you use bag and mask. In case of preterm baby, you use T-piece resuscitator. When the heart rate is 60 to 100 per minute and increasing, you will continue your bag and mask. If the heart rate is 60 to 100 per minute, but not increasing means you need to do Mr. SOPA. What is called Mr. SOPA? If you do ventilation properly, heart rate will increase. If the heart rate is not increasing, you are not doing correct ventilation, you are not doing correct bag and mask. In those cases, what you need to do? First, you need to snugly fit the mask. Second, you need to reposition the neck. 3, you need to do suction of the mouth as well as suction of the nose. 4, you need to open the mouth adequately. P, you need to give adequate pressure. And finally, if nothing is going well, then you need to give either laryngeal mask airway or you need to intubate the child. Again, this is mainly based on heart rate. Third, if the heart rate is less than 60 per minute, then along with positive pressure ventilation, you need to give chest compression. The indication for chest compression is heart rate is less than 60 per minute. It should be continued along with positive pressure ventilation in 3:1 ratio. So what does it mean? For 3 chest compression by 2 thumb technique, there you need to do 1 ventilation. And finally, if the heart rate is less than 60 per minute despite 1 minute of cardiopulmonary resuscitation, then you need to give adrenaline. At normal adrenaline availability is 1 in 1000. You need to mix with 10 ml of normal saline, so that 1 in 10,000 adrenaline. 1 in 10,000 adrenaline. In that you need to give 0.1 ml per kg. You can go up to 0.3 ml per kg. So what we have seen in this question, the successful resuscitation can be assessed by means of increase in the heart rate. If the heart rate is not increasing, then you need to go for the next step. Step 1 is positive pressure ventilation. Step 2 is Mr. SOPA. Step 3 is chest compression if the heart rate is less than 60 per minute. And step 4, despite CPR, if the heart rate is continue less than 60 per minute, then you need to give an adrenaline either through umbilical vein or a peripheral vein or an intraosseous. Rarely you can try through endotracheal tube. So the answer for this question is increase in heart rate. Question number 1 is over. Second, adrenocorticotropic hormone is the drug of choice in which of the following conditions? 1. Juvenile myoclonic epilepsy. 2. Rolandic epilepsy. 3. West syndrome. 4. Lennox-Gastaut syndrome. So, when do you use your adrenocorticotropic hormone? You all know that you can try West syndrome. In West syndrome, particularly this drug can be used for infantile spasms. Otherwise, it is known as epileptic spasm. Otherwise known as epileptic spasms. Then you need to see whether tuberous sclerosis is associated or tuberous sclerosis not associated. If tuberous sclerosis is associated, vigabatrin is the drug of choice. If the tuberous sclerosis is not associated, if ACTH is available, give ACTH. If ACTH is not available, you can give steroids. This is with respect to infantile spasms. And a bird's eye view regarding the usage of anti-epileptic drugs in seizure is follows. For atonic seizure, absent seizure, you can use valproate or lamotrigine. For atonic seizures, absent seizures, you can use valproate or lamotrigine. For focal seizures, the best drug of choice is carbamazepine. For GTCS, you can use the first drug of choice is valproate, or in the presence of any liver issues, you can use levetiracetam. And for epileptic spasms, as we discussed already, ACTH can be used, or else if it is not available, you can use corticosteroids. For myoclonic, also valproate lamotrigine. For tonic also, you can use valproate lamotrigine. So I can say for atonic, for myoclonic, for tonic, in all these seizures, the initial drug of choice is valproate. If it is not responding, you can use lamotrigine. But for focal seizures, the best drug of choice is carbamazepine, and for absent seizures you can use ethosuximide. For epileptic spasms, ACTH is the drug of choice. This is a simple gist to remember. With respect to epileptic encephalopathy, encephalopathy is associated with neuroregression. For tuberous sclerosis, as we discussed already, you can give vigabatrin. For Lennox-Gastaut syndrome, which is characterized by a triad of one is various type of seizures, tonic, atonic, various types of seizures can come, followed by neuroregression, and it is associated with the spike and wave pattern. So the triad of various types of seizures, many types of seizures along with neuroregression, along with the spike and waveform, So this is called as Lennox-Gastaut syndrome, for which you can try the same valproate lamotrigine. Majority of the time they don't work. In those instances, you can use ketogenic diet, zonisamide, acetazolamide, steroids or IVIG, but they are associated with serious side effects. Right. What is Dravet syndrome? Another important entrance MCQ is Dravet syndrome, which is nothing but vaccine-induced encephalopathy. It is nothing but vaccine-induced encephalopathy. Otherwise, we can say pertussis encephalopathy. Any child who worsens over a period of time after getting pertussis vaccination, if it shows initially febrile seizure will occur, then afebrile seizure, then complex seizure, then GTCS. Progressively, the nature of seizure will gradually worsen in those instances which occurs particularly after pertussis vaccination. We call it as Dravet syndrome. And the drug of choice here also lamotrigine, carbamazepine group of drugs, and phenytoin. So for this question, the answer is ACTH is mainly used in West syndrome. Right. The next question is, which of the following cyanotic congenital heart disease causes increased pulmonary blood flow? Which of the following cyanotic congenital heart disease causes increased pulmonary blood flow? Your cyanotic congenital heart disease are divided into two types. What are all those types? One with decreased pulmonary blood flow. In which you will get, this is called pulmonary oligemia. So this is associated with the decreased pulmonary blood flow. So pulmonary vascular markings are not seen here. I repeat, whenever you see a black lung without any pulmonary vascular markings, we call it as pulmonary oligemia. So this pulmonary oligemia causing conditions are: one, tetralogy of Fallot. Second one is pulmonary atresia. Third one is tricuspid atresia. I repeat, tetralogy of Fallot, tricuspid atresia, and pulmonary atresia. Remember, in tetralogy of Fallot and pulmonary atresia, you will get right axis deviation, whereas in tricuspid atresia, you will get left axis deviation. Second one, what is this? Here, this is associated with increased pulmonary blood flow. Otherwise known as pulmonary plethora. In these conditions, pulmonary plethora. In these conditions, okay, the following can occur. What are all the conditions that can cause pulmonary plethora? The conditions that can cause pulmonary plethora are first one is transposition of great arteries. Transposition of great arteries. 2. Truncus arteriosus. One is transposition of great arteries. Second one is truncus arteriosus. One is transposition of great arteries. Second one is truncus arteriosus. Third one is total anomalous pulmonary venous connection. Third one is total anomalous pulmonary venous connection. So these are all the conditions. Those which are associated with reduced pulmonary blood flow or pulmonary oligemia, increased pulmonary blood flow or pulmonary plethora. So which of the following heart disease causes increased pulmonary blood flow? So reduced pulmonary blood flow, variable pulmonary blood flow, increased pulmonary blood flow, increased pulmonary blood flow. So 3 and 4 I can opt for increased pulmonary blood flow. So the choice is 3 and 4. Your truncus arteriosus, your transposition of great arteries, your total anomalous pulmonary venous connections are associated with increased pulmonary blood flow, whereas tricuspid atresia, pulmonary atresia, tetralogy of Fallot are associated with decreased pulmonary blood flow. Epstein's anomaly, a variable condition. Let us go to the next question. A 4-year-old boy brought to the outpatient clinic with intentional tremors and poor scholastic performance. His sister has similar complaints. On examination, hepatomegaly is seen. The eye finding, probably they would have given a KF ring. So what is the probable diagnosis? Whenever you have a combination of liver involvement, whenever you have a combination of neurological involvement, invariably you need to think in terms of Wilson's disease. Invariably you will need to think in terms of Wilson's disease. So what is the manifestation of Wilson's disease? What are all the liver manifestation? What are all the neurological manifestation? Apart from that, what else can occur? Any kind of liver involvement in children after ruling out a normal hepatitis B, C, A, D, E, you need to invariably think in terms of Wilson's disease. It can cause acute hepatitis. It can cause chronic hepatitis. It can cause an asymptomatic hepatomegaly. It can present with overt liver failure, or it can present with chronic liver failure, cirrhosis and pulmonary hypertension. This is with respect to liver involvement. This Wilson's disease, in which copper is getting accumulated in the liver, leading on to these manifestations. And these copper can also deposit in the brain, leading on to these manifestations. What are all these? Initially, they will have poor scholastic performance, poor speech, clumsiness, convulsions. After involving the basal ganglia, it can cause chorioathetoid movement. And this excess copper can lead on to damage to the RBC membrane, leads to Coombs negative hemolytic anemia. So these are all the liver manifestation, neurological manifestation and blood manifestation. Remember, the blood manifestations are invariably due to copper induced direct damage to the RBC membrane, and it is not antibody mediated. What are all the investigations that can be done? Your serum ceruloplasmin will be less than 20 mg per deciliter. Your urine copper will be more than 100 micrograms per day. If the urine copper is less than 100 microgram per day, you can give some doses of penicillamine, after which urine copper will increase. By this way you can diagnose. And liver copper, it is an invasive test. Whenever your copper content in the liver more than 250 microgram per gram of dry weight of liver, Again, it is diagnostic of Wilson's disease. And we have a scoring system based on liver involvement, neurological involvement, blood involvement, and these above investigation. This classification, this scoring system is called Leipzig scoring. What is this scoring called? This is called Leipzig scoring method. Okay, this is called Leipzig scoring method. So they can ask you this question: in which disease this Leipzig scoring system is followed? Apart from this, you can use, right now we are living in an era of next generation sequencing, otherwise called as clinical exome analysis, in which you can find ATP 7, okay, ATP 7B mutation. 7A mutation is associated with 𝐒𝐿𝐾𝐝 hair disease. This is associated with 7B mutation. And what are all the advices that can be given? Copper rich foods such as meat, chocolate, nuts are to be avoided. And what are all the MCQs that can be asked? The most common chelator that we use in India is penicillamine. We use penicillamine. Penicillamine has got many side effects. Wherever trientine is available, trientine can be used instead of penicillamine. But as of in developing countries like India, penicillamine can be used. In Neuro-Wilson, the drug of choice is ammonium tetrathiomolybdate. Again, it is available only in a very few countries. And what is the goal of chelating agent? Whenever you give chelating agent, you need to make sure that your copper content per day in urine should be more than 200 micrograms. And finally, what is the role of zinc? Zinc can be particularly useful in asymptomatic sibling by retarding the absorption of copper. Whenever you give zinc in patients with Wilson's disease, invariably they retard the absorption of penicillamine, trientine and ammonium tetrathiomolybdate. So as of now, zinc is mainly used in asymptomatic siblings. Next question. Which alternate method can be used for the procedure in the image below? Okay. So probably I don't know whether this is a correct image or not. This is the image provided by our students through memory. Okay, probably whenever you see a child with a morphanoid habitus, a tall boy or a girl along with a arm span which is more than the height of the child, invariably you will think in terms of a morphanoid habitus. Particularly a tall boy with ectopia lentis and who is at a risk for aortic dissection, we will think in terms of Marfan syndrome. Apart from arm span, which is more than the height, what else we can see? Two important signs. So one is thumb sign, another is wrist sign. So what is thumb sign called as? Thumb sign means whenever you adduct the thumb, whenever you adduct the thumb and close it with other fingers, you cannot see your distal phalanx. If you could see my distal phalanx, then it is called thumb sign. The entire distal phalanx can be seen outside the flexed areas of other fingers. Second point, what is this called? This is called wrist sign. So what is this wrist sign? Whenever you whenever you choose your thumb and your whenever you need to choose your thumb and little finger. See, look at this. Whenever I do this maneuver, closing my wrist, look at this. My thumb and little finger are not approximating with each other. When my thumb and little finger are approximating with each other and your little phalanx and your little finger's distal phalanx is crossing the thumb, then it is called as wrist sign. So your arm span will be more than the height, then your whenever you do adduction of the thumb, what will happen? The entire distal phalanx will be seen. Again, in wrist sign, your distal phalanx will cross your distal phalanx will touch the thumb. This is called a wrist sign. All indicates hyperextensibility. All indicates hyperextensibility. Okay, this is about this question. Arm span will be more than the height of the child with respect to Marfan syndrome. A child presents with the complaints of fever, rash, body ache and throat ache. He had a history of thorn prick injury a week back. What antibiotics would you give empirically to this child? So whenever you have a child with the thorn prick, whenever you have any child with the thorn prick, invariably you can consider 𝐒𝐿, which covers gram positive, a few gram negative, along with gram positive, gram negative, along with some anaerobic organisms which can be treated by giving 𝐒𝐿. But when the other organisms that you need to consider are, one is Pseudomonas. If the child is very sick and gets admitted, you can try meropenem. But as far as OP basis is concerned, any human bite or thorn prick can be managed by giving amoxicillin clavulanic acid combination, not mere amoxicillin alone, because they are at the risk for Staphylococcus aureus. Staphylococcus aureus often produces beta lactamases, so that you need to add clavulanic along with amoxicillin. An unconscious child is brought to the casualty. What is the correct sequence of management? So this is an unconscious child. I repeat, this is an unconscious child. What is the correct sequence of management? Whenever you see any child brought with fully unconsciousness, the first thing that you need to do is assess the response. You need to call and see whether the child is responding or not. After assessing the response, you need to look for breathing, whether the child is breathing or not. Third one is assess the pulse. One is call, another one is look, third one is feel. Call, look, feel. Third one is assess the pulse. Then previously we used to say airway, breathing, circulation, but after 2015, what happened? This has been changed to CAB. This has been changed to CAB. So initially we used to give importance to airway, then you need to look for breathing, then circulation. Airway can be managed by jaw thrust maneuver, and then jaw thrust maneuver, neck extension maneuver, in newborns sniffing position, etc. But followed by breathing. If the child is, you can give rescue breathing with mouth to mouth breathing, or else you can use bag and mask, or else you can intubate the child. Finally, you give importance to compression, that is cardiac compression. But by 2015, it has been reversed. Whenever you see an unconscious patient, the first thing that you need to give importance is chest compression, followed by airway, followed by breathing. So ABC has been changed to CAB. ABC has been changed to CAB. Okay. ABC has been changed to CAB. Right? Has been changed to CAB. What other things has been? So first thing is response. Second one is breathing. Third one is pulse. Okay. Fourth one is start compression. Fifth one is bag and mask ventilation. Fifth one is bag and mask ventilation. So the answer is C. So the answer is C is the correct answer. First one is assess the response. Second one is assess the response. Second one is okay. So ABC has been changed to CAB. So this is one. Second important change is second important change is chest compression. Whenever you do chest compression, previously there is no limit of depth of compression. But right now it has been fixed to a maximum of 6 centimeter compression only should be given. Second. Third one, when you have one rescuer or when you have two rescuer. When you have one rescuer, you need to give 30:2. That is 30 chest compressions along with 2 ventilations. When you have 2 rescuers, then it is 15 ventilations along with 15 compressions along with 2 ventilations. So what are all the 3 major changes? So what are all the 3 major changes? One is ABC has been replaced by CAB, not airway. In unconscious child, compression should be done first. Second one is maximum chest compression is 6 centimeter only. Third one is 1 rescuer means 30:2. 2 rescue means 50:2. So the answer for this question is discussed in detail. Right? Okay. Which alternate to breast milk in low birth weight can be used? Low birth weight baby can be used. Even mother's milk is the best milk. Will you use cow milk, preterm formula, term formula, human donor milk? Among this option, if we had given expressed breast milk of the mother, it can be chosen. But here expressed breast milk is not given. So invariably the best thing is human donor milk. Someone's milk, human donor milk is the best one. If it is not available, if the child is less than 1500 grams, we can give preterm formula. If the child is more than 1500 grams, you can give term formula. Cow milk invariably we will avoid, but in the absence of formula milk, we will give cow milk, which is usually undiluted. I repeat, which is usually undiluted. So the best thing is first is expressed breast milk of the mother if the baby can't suck. Second one is human donor milk. Third one is term formula, preterm formula. Term formula more than 1500 grams, preterm formula less than 1500 grams. If it is not available, then we can give cow milk, undiluted cow milk. Apart from that, what other questions can be asked? All less than 1500 grams. Less than 1500 grams, you use folic acid, multivitamin plus vitamin D plus iron. More than 1500 grams, you give vitamin D plus iron. Finally, more than 2500 grams, you will give only vitamin D till 1 year. Vitamin D till 1 year. 1 year, right? and iron should be started only after 2 weeks. I repeat, iron should be started only after 2 weeks. So preterm formula less than 1500, term formula more than 1500. What else apart from that? Less than 1500 grams. Initially you start 80 ml per kg, gradually you increase to 15 ml per kg per day, gradually you increase up to on 7th day 150 ml per kg. 1500, 2500 gram vitamin D and iron. What else? What else apart from that? That's it, which were discussed previously. A 4-year-old child with a body weight of 15 kgs and a height of 100 centimeter is admitted with renal failure. His blood urea was 100 milligram per deciliter and serum creatinine was 1 milligram per deciliter. What is the closest calculated eGFR in this patient? Very simple. How do you calculate GFR? GFR can be calculated by constant K into height in centimeter divided by serum creatinine. So constant K into height. What is the height of the child? What is the height of the child? 100 centimeter divided by serum creatinine 1. So K into 100. So what is constant K? K is usually 0.55. For this 4-year-old, K is usually 0.55. So 0.55 into 100 equal to 55. 55. K usually varies. Remember, for preterm it is 0.3. For term it is 0.4. For children it is 0.5. Since this is a 4-year-old child, K constant here taken was 0.55. So the answer is 55 ml per minute per body surface area. I repeat, constant K into height in centimeter by serum creatinine. Serum creatinine. So this is Schwartz formula to find out your approximate GFR based on the height and serum creatinine. A child presents with acute exacerbation of asthma. Which of the following would you do? Chest X-ray, oxygen administration, salbutamol nebulization, administration of oral corticosteroids. Tell me what are all the things you need to do. What are all the things you do? A child presents with acute exacerbation of the asthma. Which of the following would do? Okay, so very simple. Your exacerbations are usually divided into mild, moderate, and then severe. Exacerbations are usually divided into mild, moderate, and severe. Okay. Mild exacerbation, moderate exacerbation, and severe exacerbation. What do you mean by? So what are all the things we will see? One is sensorium. Second one is your V's heard during end expiration or full expiration or both during inspiration and expiration. Second one. Third one is your peak expiratory flow meter. Fourth one is peak expiratory flow meter. Fourth one is your saturation. Fourth one is your saturation. For mild exacerbation, let me say your sensorium will be fine. Your sensorium will be fine. V's will be heard in end expiration. PFR will be more than 80 or between 70 to 80. SpO2 will be normal. Whereas SpO2 will be normal. Whereas moderate exacerbation, the child will be irritable. Your V's will be heard in full expiration. Saturation somewhere between 90 to 93. PFR between 60 to 80. And finally, Whenever you have severe exacerbation, child will be lethargic. You will have silent chest. PFR will be less than 60. Saturation will be less than 90. This is a rough calculation to find out the severity of asthma. So what are all the things we will do in case of asthma? So this is with respect to severity of asthma. So mild exacerbation, do you use nebulizer? No need to use nebulizer. For mild exacerbation, you can do metered dose inhaler, that is spacer with mask. Spacer with mask. You can use short acting, that is SABA. In India, the commonly used SABA is salbutamol. Salbutamol, and you can use salbutamol 1 puff every 10 minutes. You can go up to many puffs. Okay. So right now mild asthma exacerbations are managed with the help of SABA with metered dose inhaler. In case of clinic practice, if the child is not having spacer, then you can do salbutamol nebulizer 20 minutes once for the next 2 hours. For moderate asthma, as we discussed, saturation between 90 to 95, PFR 60 to 80. Your bronchi will be heard during both inspiration and expiration. And here you can't use moderate asthma. You can't use spacer with mask. Here you can use nebulizer. In that nebulizer, every 20 minutes, you can give the beta 2 agonist salbutamol that should be driven with oxygen. Instead of nebulizer, in medical colleges, oxygen driven nebulizations will be done. The pressure will be given by oxygen. So by giving oxygen along with salbutamol, you can avoid ventilatory perfusion mismatch and worsening of asthma. So I repeat, moderate exacerbation should not be given only nebulization with salbutamol. It should be oxygen driven nebulization of salbutamol. Always give any form of steroids. It can be oral prednisolone, IV dexamethasone, methylprednisolone, or hydrocortisone. If the child is not responding to your SABA every 20 minutes, at the end of 1 hour, along with SABA, you can add ipratropium bromide. So for the next 1 hour, salbutamol along with ipratropium bromide for each every 20 minutes. So first hour salbutamol, second hour salbutamol along with ipratropium. At the end of second hour. But in cases of severe life-threatening asthma in which there is silent chest, so that there is severe bronchoconstriction, and neither your salbutamol nebulization nor your ipratropium bromide will work, in those instances you can consider either subcutaneous adrenaline. You can give subcutaneous adrenaline in silent chest. Then if the child is having life-threatening asthma with silent chest, apart from adrenaline, salbutamol and ipravent, you need to consider magnesium sulfate. Magnesium sulfate 50 mg per kilogram in dextrose containing solution over 30 minutes. If the child still not responding, you can go for terbutaline. But in countries like India, beyond magnesium sulfate, still people are considering aminophylline infusion despite having a narrow therapeutic index. Okay, what else? That's it. Narrow therapeutic index. So I repeat, oxygen driven nebulization every 20 minutes once for the first hour. Second hour, oxygen driven nebulization with salbutamol as well as ipratropium bromide. Consider steroids. Third, add magnesium sulfate. If the child still not responding to continuous nebulization of salbutamol and ipra-vent. Okay, subcutaneous adrenaline or intramuscular adrenaline should be considered before starting salbutamol or ipra-vent if you have a silent chest. Okay, I repeat, mild exacerbation can be managed with metered dose inhaler along with spacer and mask with salbutamol. So what is the answer for this question? Oxygen administration I will do, salbutamol I will do, I will give oral corticosteroids. So 2, 3, 4 I will do. I will not prefer chest x-ray. There is no need for chest x-ray because if you have a clear-cut case for asthma exacerbation, no need for chest x-ray. So answer 2, 3, 4 are correct. Next, which of the following increases the risk of recurrence of febrile seizure? We all know that febrile seizure. Febrile seizures, you have two types, typical febrile seizure and then atypical febrile seizures. Typical febrile seizure, 1 episode per day. It usually occurs at the height of temperature and there will be no focal neurological deficit and it lasts less than 5 minutes. Whereas atypical febrile fits are characterized by more than 1 episode per day and it occurs with a short rise of temperature and there might be focal neurological deficit and it lasts for more than 5 minutes. When mothers ask whether my child is going to get this recurrence, what are the risk factors you need to consider? If the child developing febrile seizure at a very young age of less than 1 year, it is prone for recurrence. If there is a positive family history, either father and mother, if they had febrile seizure when they were young, then there are chances for recurrence. Seizure occurring with just 98°F, 99°F are prone for recurrence. And finally, seizure occur immediately after the onset of fever are prone for recurrence. To be correct, first, second, 3, 4 are all correct. Younger the age of less than 1 year, febrile seizure in the first degree relative, seizures with low temperature, brief duration between fever onset and seizure are prone for recurrence for febrile seizure. Febrile seizure. Next question. Choose the most appropriate answer. In phenylketonuria, urine has mousy odor. The answer is correct. Urine has got mousy odor or musty odor. The serum assertion is this one. Reason is the serum level of tyrosine, dopa and norepinephrine decreases in phenylketonuria. Let us see. So phenylalanine is converted into tyrosine. From tyrosine you will get dopa, you will get all catecholamines. This phenylalanine is converted to phenylalanine hydroxylase, the enzyme, and the cofactor is tetrahydrobiopterin. So what will happen when this phenylalanine hydroxylase is absent? Phenylalanine will be increased in the blood. Phenylalanine will be increased in the blood, which will be converted into phenylacetate, which is responsible for this mousy odor or musty odor. And previously we used to do Guthrie's test. What is the test? Guthrie's test, in which they will add perchlorate to the urine, and if phenylalanine is present, it will be changed to blue-green color. That is the old Guthrie's test. And you all know, whenever phenylalanine hydroxylase is absent, your tyrosine, dopa, catecholamine all will be reduced. So A is correct, B is correct, but B is not the correct explanation of assertion. So the answer is C, because the odor, mousy odor or musty odor, are mainly due to due to phenyl acetate, and it is not due to increased level of phenylalanine, or not due to reduced level of tyrosine, dopa, or norepinephrine. Next question. A child with thalassemia is undergoing multiple blood transfusion. What is the best method to detect iron overload? Very simple. All thalassemic children will require iron chelators, particularly if they have been receiving transfusions of more than 1 year, if there are more than 10 to 15 transfusions, or if the serum ferritin is more than 1000 nanogram per ml, or if the liver iron is more than 500 micrograms per gram of dry weight of liver. In these conditions, you need to start iron chelator. Remember, your liver, by doing a liver biopsy and finding the amount of iron in the liver tissue is a cumbersome procedure, and it is an invasive procedure. Right now, quantification of liver being affected by your what is that, iron, or cardiac being affected by iron. Right now we have non-invasive method. What is that non-invasive method? The non-invasive method is R2 MRI of liver, which is some technique of MRI, R2 phase of liver, or T2 MRI of cardiac heart. So these are all the two non-invasive, MRI of liver and MRI of heart. These are all the non-invasive methods to find out the iron deposition in the liver. So it is more often an MRI. Liver iron we don't do right now. Serum ferritin, yes, we do. Right now we rely more on MRI of liver or MRI of heart. Liver or MRI of heart. We have, what are all the chelators we have? The chelators we have are desferrioxamine, deferrixerox, or deferriprone. Each and every one has got its own toxicity. Okay, toxicity. Right. So the answer is non-invasive method of finding out iron deposition in liver and heart is through MRI. Next, a child presents with cold feet and history of wearing socks even in summer on examination. Lower limb pulses are diminished compared to radial pulses. Prominent radiofemoral delay is present. What is the underlying condition? We all know that it is nothing but a case of coarctation of aorta, in which you will have palpable brachial pulse, whereas non-palpable femoral pulse. Brachial pulse will be palpable, whereas femoral pulse is not palpable. Okay, brachial pulse is palpable, whereas femoral pulse is not palpable. Okay, and usually you will have femoral pulse before radial pulse. Whenever you have coarctation of aorta, this has been changed to radial pulse you will have before femoral pulse. Radial pulse you will have whenever you have coarctation of aorta, you will have femoral pulse more before radial pulse. But when coarctation is present, you will hear radial, you will feel radial pulse before femoral pulse. And coarctation, usually preductal coarctation or postductal coarctation, based on the origin of the ductus arteriosus, whether before based on the position of the narrowed segment of the artery with respect to ductus arteriosus. If above the level of the ductus arteriosus, there will be aortic arch hypoplasia. I repeat, if it is above the level of the ductus arteriosus, there will be aortic arch hypoplasia. In this condition, the child will present with shock. So any newborn by about 4th or 5th day presents with shock. with a palpable brachial pulse and non-palpable femoral pulse, think in terms of coarctation of aorta, and you need to start prostaglandin E1 and analog immediately. But when the coarctation occurs postductal, invariably it will manifest as claudication in child whenever the child is playing. So this is coarctation of aorta distal to the subclavian artery. So with respect to coarctation of aorta, invariably they will be associated with the bicuspid aortic valve. You will have short systolic murmur heard in the left third or fourth sternal edge, and this murmur will be radiated to the infrascapular angle. But whenever you hear continuous murmur on the lateral chest, it means that the child had developed collaterals. Preductal coarctation, infantile type, associated with aortic arch hypoplasia, presents with shock, whereas children presents often with claudication of lower limbs. But what happens in case of untreated long-lasting coarctation of aorta along with PDA? They will develop differential cyanosis in which upper limb will be normal, lower limb will be cyanotic. Radiofemoral delay, it was discussed in detail. Preductal coarctation, aortic arch hypoplasia. Postductal coarctations usually presents with claudication of limbs. That's all about coarctation of aorta. Which of the following statements are true regarding cytomegalovirus? Cytomegalovirus is the most common congenital torch infection. I repeat, most common congenital torch infection. Cytomegalovirus. Most common cause for sensory neural deafness. I repeat, most common cause for sensory neural deafness. Third one, sensory neural deafness. Third one, it is associated with periventricular calcification in the brain. Associated with periventricular calcification in the brain. Next one. Remember, child can be asymptomatic at birth, but gradually they can develop sensory neural deafness. This is very important. Child can be initially normal, but later on they will develop sensory neural deafness. Next point, sensory neural deafness. What is the investigation of choice? Less than 3 weeks. Urine PCR, or you can do IgM, ELISA for CM. Most specific is urine PCR in children less than 3 weeks in child who is born within 3 weeks. Okay, within 3 weeks. Right. So, what other things? Neonates who are asymptomatic but have lesser risk for later sequelae? Not at all. As we discussed already, they can be initially asymptomatic, but later on they can develop sensory neural deafness. 20 to 40% are symptomatic at birth. Let us see. The transmission rate of CME infection to the infant is more common from primary maternal infection than reactivation. Let us see. Diagnosis by urine specimen at 4 weeks of age. Let us see one by one. Remember, in case of primary infection, when the mother is affected for the first time, there is 30% chance for transmission. In that, only 10% will be symptomatic. When the mother is having reactivation or reinfection, there is less chance, 1% transmission. In that, 5 to 10% will be asymptomatic. In India, reactivation and reinfections are more common than primary infection. Transmission occurs throughout pregnancy. Remember, 10% 90% of them will be asymptomatic. 10% will be symptomatic even when affected. Severe multi-organ dysfunction like hepatitis, chorioretinitis, nephritis will occur less than 5%. As usual for any torch infection, microcephaly, a small for gestational IUGR baby, petechiae and hepatosplenomegaly can occur. Periventricular calcification has been described. Most common is long-term sequelae is hearing loss. Hearing loss. Apart from that, what else? I repeat, urine PCR is the investigation of choice. Investigation of, particularly when there is an hearing loss, when there is meningitis, or when there is progressive disease, 6 weeks of IV 𝐒𝐂𝐈𝐀 followed by 6 months of oral 𝐒𝐂𝐈𝐀 can be tried. People have started using val-𝐒𝐂𝐈𝐀 instead of oral 𝐒𝐂𝐈𝐀 too. Okay, so with respect to this question, first is definitely wrong. Diagnosis is by urine specimen at 4 weeks of age. This is correct. In developing countries, most often it is due to reactivation rather than primary infection. Symptoms, look at this. Symptoms are just 10%. To be very frank, only 4 is correct. I don't know the choice chosen by the person who gives the MCQ is wrong or not. So, if this is 10%, then we can vote for 2 and 4. If this is 10%, we can vote for 2 and 4. Or else, strictly speaking, 4 is the only correct answer. Let us go to the next question. A child is brought to casualty with a history of choking. On examination, decreased air entry in the left lung. What would be the correct management? You need to take an X-ray chest to look for obstructive emphysema, and then you need to do a rigid bronchoscopy to remove the foreign body. No need for CT, no need for ICD infection. This is a case of foreign body in the left main bronchus. Whenever any child develops sudden onset cough with a history of choking with a reduced air entry on one side, immediately you need to take an X-ray. Look at this. If you have a foreign body on the left main bronchus, during inspiration air goes inside. During expiration, which is a passive process, air cannot come out, as a result of which you will get an increased aeration and volume of lung. This is called as obstructive emphysema. And you need to do a bronchoscopy. To find out the foreign body in the left main bronchus. Usually it is groundnut. It can be removed usually by a rigid, but right now flexible fiber optic bronchoscopies are also used. So this is a case of foreign body ingestion, in which X-ray will show obstructive emphysema, which can be removed either by a rigid or flexible bronchoscopy. At what age the height of the child is half of its adult height? Let us see one by one. Usually less than 2 years you use infantometer, and more than 2 years you use stadiometer. At birth usually the child is 50 centimeter. At 3 months 60 centimeter, 6 months 65 centimeter, at 1 year 75 centimeter, at 2 years 87 centimeter. At 4 years 100 centimeter, and between 6 to 12 years it is 6 centimeter per year. If it is less than 4 centimeter per year, I repeat, if it is less than 4 centimeter per year, then invariably you need to think in terms of either growth hormone deficiency or thyroid hormone deficiency. The height of the child at 2 years is usually usually off. So what we do, whenever any mother will ask us what will be the Predicted height of the child, you have predicted height of the child mid-parental height, in which father height divided by 2 plus mother height divided by 2. If it is a boy, plus 6.5. If it is a girl, minus 6.5. This calculation you know. But any child, when you multiply any child's height into 2 at 2 years, invariably you will get the normal predicted height. It is usually a rule of thumb. The height of the child at 2 years is half of the adult height which he is going to achieve. So the answer is probably 20 to 24 months, 2 years. Height of the child half of adult height is, I repeat, 2 years. 2 years. Then match the following. Social smile. Social smile usually occurs by about 1 to 2 months. Pincer grasp usually start by 9 to 11 months. Walking 1 to 2 steps usually occurs by 12 to 13 months. Transfer of objects usually by about 6 to 7 months. So social smile A. So this is the correct answer. Milestones. What dose of dexamethasone is given to a pregnant lady expected to deliver a preterm for fetal lung maturity? Very simple. Betamethasone or dexamethasone. Betamethasone is total dosage you need to give 24 milligram. Betamethasone is long acting, so you give 12 milligram 24 hours apart, 2 doses. Dexamethasone is short acting, so you give 6 milligram 4 doses 12 hours apart. You can start giving from 24 weeks to 34 weeks. And the only absolute contraindication is chorioamnionitis. Apart from fetal lung maturity, your hyaline membrane disease will reduce. Your retinopathy of prematurity will reduce. Your necrotizing enterocolitis will reduce. And your intraventricular hemorrhage will reduce. So here the question is dexamethasone. You need to give 6 milligram 4 doses 12 hours apart. Answer is D. Answer is D. So these are all the things we discussed right now. Causes of seizures in neonate are which of the following? Most common cause is hypoglycemia followed by hypocalcemia. Very rarely you will get hypomagnesemia, and hyponatremia can also be a cause. I can say all can cause. I repeat, I can say all can cause except hypernatremia. Hypernatremia usually is a rare cause. So common causes 1, 2, 3 are correct. There are 3 types of seizures with respect to EEG and clinical seizures. Clinically, it can be a subtle seizure. It can be a tonic, clonic or myoclonic seizures. With respect to EEG and clinical, if both EEG and clinical is present, electroclinical seizures. If only clinical but there is no EEG, it is called clinical. Electrical only without any clinical manifestation. The most common cause for seizure in newborn is subtle seizure, and most common cause is hypoxic ischemic encephalopathy, followed by hypocalcemia, hypomagnesemia, hyponatremia. Not to forget meningitis, intraventricular bleed and kernicterus. Very rarely it can be due to epileptic syndromes and malformations like lissencephaly or schizencephaly. Whenever you get stimulus sensitive rigor like movements, it is called jitteriness. And you can have benign sleep myoclonus, which occurs only during sleep. When you have a child with a seizure, it should be immediately corrected by giving 2 ml per kg of 10% dextrose, followed by phenobarbital. If seizures still occur, you can try levetiracetam or phenytoin. Despite that, if seizure continue, you can consider IV midazolam. And finally, if nothing works, IV lignocaine. Remember, IM pyridoxine can be considered in refractory neonatal seizures. I repeat, IM pyridoxine can be considered in refractory neonatal seizures. So the answer for this question is 1, 2, 3. Hepatitis subunit vaccine is derived from which antigen? Directly goes without saying, hepatitis B surface antigen, and it is preserved with aluminum adjuvant. Usually 0 dose 6 weeks, 10 weeks, 14 weeks, but better efficacy is 0, 1, 6. When you have a titer of more than 10 microunits per ml, you are said to be protective. When mother is hepatitis B surface positive, you should give 4 doses of hepatitis B along with 0, 6 weeks, 10 weeks and then 14 weeks. Along with hepatitis B immunoglobulin within 24 hours. If hepatitis B immunoglobulin is not available, then accelerated schedule. What is this accelerated schedule? 0, 1, 2, 6 is called accelerated schedule. That also can reduce the vertical transmission by about 90%. 0, 1, 2, 6 schedule for those newborns whose mother is hepatitis B positive but hepatitis B immunoglobulin is not given. Then you need to follow this accelerated boosting schedule of hepatitis B vaccine. Most common cause for urine flow obstruction in a boy. Whenever you see any boy whose urine stream is poor, invariably you need to think in terms of posterior urethral wall. This posterior urethral wall, whenever you don't ask this question in any male newborn, invariably what will happen? It can lead to recurrent urinary tract infection, and it can also lead to dribbling of urine. Whenever you see the suprapubic area, you can have a palpable urine bladder. So always ask any male newborn at the first instance whether the urine stream is good or bad. Good or bad. The clues are palpable bladder, dribbling of urine if it is not identified correctly. Antenatally, because of severe obstruction, there can be bilateral hydroureteronephrosis. Because of long-standing obstruction, your bladder will be enlarged with numerous diverticulation and trabeculations. Poor urinary stream can lead to oligohydramnios. All cases of posterior urethral wall because of back leak and damage can have some form of renal dysplasia. What is the investigation of choice? Micturating cystourethrogram is the investigation of choice in which you will have a dilated posterior urethra, you can have an enlarged diverticular and trabeculated bladder and secondary vesicoureteric reflex leading on to hydroureteronephrosis. The treatment of the child, if there is no sepsis and there is no massive dilatation of the bladder, you can try endoscopic urethral fulguration. But when the child is having severe enlargement of bladder with diverticulation or trabeculation, you need to give rest to the bladder by doing bilateral ureterostomy or vesicostomy. Remember, progressive kidney damage will occur, and there are many cases in which despite doing transurethral fulguration, there is a bladder dysfunction. So the most common cause for flow obstruction in a male is posterior urethral valve. What disease has impaired collagen synthesis? Very simple. It is scurvy, vitamin C, whereas rickets is associated with D, beriberi associated with thiamine, whereas night blindness is associated with vitamin A. Thiamine is associated with dry beriberi, wet beriberi. Dry beriberi is characterized by peripheral neuropathy, whereas wet beriberi is characterized by CCF, and it can be associated with infantile aphonia. I repeat, it can be associated with infantile aphonia. Your B12 or riboflavin is associated with angular stomatitis, cheilitis, nasolabial seborrhea, and corneal vascularization. B3 or niacin is associated with, you all know, more common in maize eating countries in which tryptophan will not be released, from that niacin will be produced, leading to niacin deficiency, causing diarrhea, dermatitis, dementia, death. B6 pyridoxine is it can be used in INH induced peripheral neuropathy. It can be used in refractory seizures in newborn. It can also be used in homocystinuria. It can also be used in sideroblastic anemia. Whereas pantothenic acid deficiency occur in only experimental animals. Burning feet syndrome along only in experimental animals where deficiency is made to occur. Biotin, suspect any child with a neuroregression and alopecia for multiple carboxylase deficiency. Excuse me. And biotin will be adhered to the avidin in the egg. By boiling egg, you can destroy avidin, as a result of which free biotin will be available for multiple carboxylase enzymes. B12, cobalamin. The manifestations are macrocytic megaloblastic anemia, hyperpigmented knuckles, neuroregression, infantile tremor syndrome, pancytopenia, hemolysis, as well as thrombotic tendency, because homocystinuria will rise. A serum cobalamin of less than 200 picograms per ml, or the screening test is urine methylmalonic acid will increase and urine homocysteine will be increased. Vitamin C ascorbic acid usually leads to impaired collagen synthesis, impaired wound healing. Along with, you can have scorbutic rosary, you can have hemopericardium, hemopericardium, cerebral hemorrhage, increased capillary fragility. You all know that in radiology you will have pencil thin cortex, white line of Frenkel, Pelken's spur, tremor-filled zone, as well as Wimberger epiphysis. Take 100 ml of orange juice or tomato, you will be fine then. It will produce tremendous vitamin C. Folic acid, most common cause for folic acid leading to deficiency is hemolysis in preterm. I repeat, hemolysis in preterm. Suspect folic acid deficiency whenever you have reticulocytosis, anemia, and minimal jaundice. Suspect in a preterm of 34 weeks, suspect folic acid deficiency. That's why any newborn who is less than 1500 grams, folic acid will be invariably given to prevent this. In folic acid deficiency, methylmalonic acid will be normal, but homocysteine will rise. Folic acid will also lead to macrocytic megaloblastic anemia. But B12 deficiency is more common than folic acid deficiency in causing macrocytic megaloblastic anemia. So whenever you treat a child with a macrocytic megaloblastic anemia, what is macrocytic? More than 100 femtoliters. RBC volume. What is megaloblastic? More than 6 lobes of neutrophils. Is hypersegmented neutrophils. When you have this condition, first give B12 followed by folate. If you don't give B12 and if you give folate, the neurological manifestations of B12 will manifest. Vitamin A, you have conjunctival xerosis, You have Bytard spot, corneal xerosis and corneal ulcer, night blindness, fundus, corneal scarring, etc. The treatment carotemia means yellowish discoloration without involvement of sclera. The treatment as far as IMNCA guidelines is concerned, 1, 2 and 14 days. Less than 6 months, 50,000 international units. 6 months to 1 year, 1 lakh international units, and more than 1 year, 2 lakh international units. Vitamin A oil 1 ml contain 1 lakh international units. Acute hypervitaminosis A will cause pseudotumor cerebri, whereas chronic hypervitaminosis A will cause painful joints, alopecia, along with hepatosplenomegaly. Vitamin D deficiency is associated with rickets. Previously, STOS regimen will be followed. STOS regimen will be followed, in which you give 6 lakh units of vitamin D. But right now it is replaced by less than 1 year, more than 1 year. Less than 1 year, 2000 international units of, less than 1 year, 2000 international units of vitamin D daily for 12 weeks. But beyond 1 year, it is 3000 international units per day for 12 weeks. At the end of 12 weeks, you will have zone of provisional calcification. STARS regimen is not followed nowadays because it is more prone for nephrocalcinosis and calcium deposition in kidney. Vitamin E deficiency can lead to hemolysis in preterm. Hemolysis in preterm, vitamin E, which was seen right now. Excess vitamin E can lead to vitamin K. Why hemolysis occurs in preterm less than 24 weeks? Because vitamin E is an antioxidant. Finally, vitamin K can lead to hemorrhagic disease of newborn. It is classic hemorrhagic disease of newborn is because it occurs 1 day to 1 week. Now, it occurs due to absence of giving vitamin K administration after birth. Less than 1 day, it is called early hemorrhagic disease of newborn, which occurs due to maternal ATT or anticonvulsant. Whereas after 1 week, it is most often due to neonatal cholestasis. Which one? Vitamin K deficiency induced bleeding. Arrange in next question. Arrange in ascending order the following causes neonatal mortality: sepsis, prematurity, congenital anomaly. Sepsis, prematurity, congenital anomaly, birth asphyxia. So as far as the data goes like this is with respect to neonate. The most common is prematurity 27%, 1, followed by birth asphyxia, 2, so B, and then followed by D, and then sepsis, which includes pneumonia, meningitis, diarrhea, so followed by A, and finally congenital anomalies. So the most common cause is preterm. Followed by birth asphyxia, followed by sepsis, neonatal mortality causing conditions. Next question. Which of the following is most effective treatment of severe COVID-19 in a child? Ivermectin don't have a role. Usually, moderate cases will receive steroids. Plus or minus remdesivir. Is the treatment of choice. Plus or minus remdesivir. 1 second. Plus or minus remdesivir. Okay. So what about the ICMR classification states that mild cases without any lower respiratory tract infection, moderate cases with tachypnea, hypoxia of 90 to 93, and severe cases are characterized by hypoxia of less than 90%, along with critical cases are characterized by ARDS, mild no respiratory involvement, moderate SpO2 between 90 to 93, severe saturation of less than 90%, critical characterized by ARDS, shock, thrombosis and multi-organ dysfunction. The investigation of choice is RT-PCR that you all know, rapid antigen detection test that has got only 50% sensitivity, whereas RT-PCR involving saliva, nasopharyngeal, oropharyngeal, sputum or ball can detect say in 70%. Antibody detection only for the diagnosis of multisystem inflammatory disease associated with COVID, which usually mimics Kawasaki-like illness, and in epidemiological surveys and immunogenicity to find out the immunogenicity of the vaccine. X-rays, ground glass opacity, subpleural in the peripheries. Mild cases, no, just supportive treatment. Moderate cases, only oxygen along with the steroids. Only in severe cases do we consider steroids with or without remdesivir, with or without IV methylprednisolone, with or without remdesivir. So in moderate severe cases we use prednisolone. Only in severe cases we try remdesivir. Remember, there is no role for azithromycin, hydroxychloroquine, favipiravir and convalescent plasma. Isolation 7 days in mild disease, 14 days in severe disease. Then intussusception is caused by which following vaccine? Excuse me one second. Which following vaccine? Intussusception is caused by which following vaccine? You all know that intussusception will be caused by rotavirus vaccine. Measles vaccine can be associated with thrombocytopenia. Measles vaccine is associated with thrombocytopenia. Typhoid we give only IM. Now it is conjugate vaccine, no major side effects. Oral polio vaccine can lead to vaccine derived poliomyelitis or vaccine associated poliomyelitis. Rotavirus is associated with intussusception. Measles, thrombocytopenic purpura. It can be also associated with encephalopathy. Tetanus vaccine, brachial neuritis. Pertussis, encephalopathy. BCG, left axillary adenopathy. Remember, any vaccine, live vaccine, which doesn't contain any preservative or any antiseptic are prone for toxic shock syndrome. So any live vaccine, when you reconstitute, use within 4 hours of reconstitution. Okay, right. Most common manifestation of juvenile dermatomyositis is Gottron papules. So, juvenile dermatomyositis is characterized by major criteria: heliotrope rash over eyelids and Gottron papules over interphalangeal joints, along with either proximal muscle weakness. Clinically, whenever muscle is damaged, CPK will be raised. Whenever muscle is damaged, EMG will be altered. Whenever muscle is damaged, you can do a biopsy and look for pesifascicular atrophy. But whenever you have a heliotrope rash or Gotron papules, along with 3 of the above, it is called definite. When 2 of the minor criteria, it is called probable, and 1 it is called possible. Right now we don't do this criteria. It is replaced by non-invasive investigation such as MRI thigh. In MRI T1 and T2 weighted images, we can find out whether there is a muscle inflammation or not. T2 images are characterized by muscle necrosis and inflammation. T1 is characterized by fibrosis, fatty infiltration. Assessment as disease severity by nail bed capillaroscopy, which can find out dropouts of capillaries. The treatment of choice is methylprednisolone and methotrexate. Next question. What is the decreasing order of cause of death in the age group of 1 to 4 years? It is pneumonia, first one, followed by diarrhea. So pneumonia, first one, followed by diarrhea. So it is B followed, C followed by B. Along with measles, meningitis, 2%. Measles, meningitis, 2%. And then measles, meningitis, pertussis, malaria, tetanus, very, very rare. Injuries, very, very rare. So C and B. C followed by B, D, A will be correct answer. Most common cause is pneumonia, followed by diarrhea, followed by measles, meningitis. 11% pneumonia, diarrhea 9%, measles, meningitis 2%. Others are very, very less. Next question. A 3-year-old child with palatable abdominal mass. Palatable abdominal mass means it is renal mass. Palatable is renal mass with history of hematuria. Any palpable abdominal distension along with hematuria, you need to think in terms of Wilms tumor. Wilms tumor, which the usual presentation of Wilms tumor is asymptomatic abdominal mass. I repeat, asymptomatic abdominal mass is the most common manifestation of Wilms tumor. Manifestation of Wilms tumor in with CT abdomen is the investigation of choice, which will find out whether it is a solid or cystic, whether calcifications present or not, whether it crosses the midline or not. Calcification, crossing the midline are common manifestations of neuroblastoma rather than a Wilms tumor. Okay, so the answer for this question is Wilms tumor. You need to go for contrast enhanced CT. Pentavalent contains very, very simple diphtheria, pertussis, tetanus, hepatitis B and Haemophilus influenza. It is given at 6 weeks, 10 weeks and 14 weeks. Pentavalent vaccine. Diphtheria, pertussis, tetanus, it is not polio. Diphtheria, pertussis, tetanus, no. No, it is answer A. Diphtheria, pertussis, tetanus, hepatitis B and Hep. Which one? Pentavalent vaccine. IPV is separate. Pneumococcal conjugate vaccine is separate. So at 6 weeks and 14 weeks, you give pentavalent vaccine, IPV and pneumococcal conjugate vaccine along with Rota, along with OPV. Whereas at 10 weeks, you give pentavalent vaccine, Rota and you will give OPV. You skip IPV and PCV. Okay, at 9 months, you give MR, you give oral polio vaccine, you give GE. At about 15 to 18 months, JE2, you will give MR2 and then you will give DPT booster and then OPV. 5 years, you will give DPT alone. By about 10 years, it is capital T small d. By about 16 years, you will give capital T, small t. This is with respect to national immunization schedule. The new thing at the 9th month is, apart from MR, OPV, JE, they had added PCV booster as well as IPV intradermal at 9 months. So at 9 months, you will give MR, you will give DPT, you will give JE1, you will give IPV, and you will give PCV. These are all the new changes recently made in this year. What are all the components of kangaroo mother care? Components of kangaroo mother care is skin to skin contact, exclusive breastfeeding, as well as yearly discharge from the hospital. I repeat, yearly discharge from the hospital. So skin to skin contact, breastfeeding, and yearly discharge. Kangaroo mother care can be done for stable LBW babies with or less than 2000 grams. Sick neonates or neonates requiring radiant warmer incubator should receive kangaroo mother care only when they are hemodynamically stable. Infants who receive IV fluids, CPAP, can have intermittent sessions. Mother should be free from any illness. Okay, very, very important. Kangaroo mother care positioning, head should be over one side extended, facing the breast so that the child can, why facing the breast so that the child can suck, why extended, airway will be open. Hips should be flexed and abducted in frog leg position. The baby's abdomen should be at the level of the mother's epigastrium so that mother's respiration, movement of the abdomen will stimulate the baby's respiration. Always it should be a little bit longer sessions lesser than 1 hour should be avoided. Mother can be in semi-recumbent position at 30 degrees. Generally, you can't do kangaroo mother care when the child is more than 2500 grams because the child will be on their own, and if it crosses more than 37 weeks. Okay. The correct option for next question. The correct option for the findings of the physiological jaundice is, physiological jaundice is due to increased indirect bilirubin and one is increased indirect bilirubin. Second one is increased urobilinogen. So direct nahi hai, indirect bilirubin, increased urobilinogen. Very good. So this is the correct answer. Decreased urobilinogen is increased. Urobilinogen is increased. So D is the correct answer, because urobilinogen, when it is absent, it is called obstructive jaundice, because urobilinogen is formed in the intestine. Okay, since it is indirect bilirubin is fat soluble, it cannot be excreted in the urine, so decreased urine bilirubin. So answer is D. Hemolysis leading to increased indirect bilirubin, and this increased bilirubin after conjugation getting converted into urobilinogen, which is getting absorbed and excreted in urine again. So it is suggestive of hemolytic jaundice. Since it is water insoluble, it cannot be excreted through urine. Answer is D. A 1 week old female neonate presents to the emergency with pale color, yellowishness of pale color, yellowing of whiteness of very pale, swelling all over the body for the past 2 days, 1 week old. Ultrasound shows enlarged liver. The doctor sends the patient blood test which shows raised serum bilirubin and low RBC. Okay, which of the following disorder is responsible for this condition? Usually it is hemolytic jaundice. But in which spleen will be enlarged more than the liver. Apart from that, it can also be due to, I don't find anything related to bacterial meningitis, apnea of prematurity, etc. Okay, increased serum bilirubin and decreased RBC is suggestive of hemolysis. Excess hemolysis can in turn causes enlarged liver because of prolonged conjugation, and it can also lead to increase in spleen because hemolysis occurs in spleen. Liver enlargement can be due to extramedullary hematopoiesis. The answer is A, hemolytic anemia. A 11-year-old girl is brought to the emergency department by her parents. They went to a party yesterday. There is 10 bowel movements every 8 hours. Blood pressure is low and pulse rate is low. Temperature is normal. Which of the following feature of severe dehydration? From top to bottom, severe dehydration features are dry eyes. First one is sensorium. Lethargy. The child is lethargic. Sunken eyes. Absent tears. Very dry tongue. Not able to drink. Skin pinch goes back very slowly, taking more than 2 seconds. Treatment of choice is 100 ml per kg of oral. So here vomit, drowsy child indicates yes, lethargic child yes, skin retracts very slowly. C more than B, I can think. I usually vote for drowsy child is there, irritable child is there, lethargy not able to respond is more in favor of severe dehydration. To my knowledge, B and C both can come. But if you want to vote one, C more than B. 36. A 2-week-old preterm male neonate presents to the emergency with yellow skin, lack of appetite and drowsiness for the past 4 days. The doctor has sent neonate blood for lab evaluation. On testing, bilirubin was found to be 16 mg per deciliter. The doctor advised phototherapy. During phototherapy, what happens? 3 things. Structural isomerization, which involves rapid excretion of lumirubin. Bilirubin will be converted into lumirubin. I repeat, bilirubin will be converted into lumirubin. Since it is fast, it is the major cause for excretion. Structural. So the answer is lumirubin. Whereas in configurational isomerism, Z isomer will be converted into E, which is slow and reversible. And finally, photooxidation will be excreted in urine. So bilirubin is converted into lumirubin by structural isomerization, which is the most common cause for the mechanism by which phototherapy works. Lumirubin, mechanism by which phototherapy works. Then 38. A 6-year-old child presenting to the pediatric, 1 second, I'll connect the charger. One second. One second. Okay. A 6-year-old child presented to the pediatric emergency with his mother complaining of cough, wheezing, everything. The child was agitated. On examination, respiratory rate was 36 per minute, pulse rate and expiratory wheeze is heard. The rest of the physical examination was unremarkable. They are explaining a case of acute severe asthma. Which of the following findings supports the diagnosis of asthma? Less than 5 years, we don't call it as asthma. It is episodic wheezer or multi-trigger wheezer. More than 6 years only, we will call it as persistent asthma or intermittent asthma. You know, asthma is a disease of reversible bronchodilation or reversible bronchoconstriction that can be identified with the help of doing peak expiratory flow meter. When your diurnal variation is more than 20%, morning your PFR is high, evening is low. When it is less than 80% of the predicted for that age, sex and ethnicity, and after bronchodilator there is more than increase in 20%, all in feature of asthma. With respect to FEV1, an increase in FEV1 of more than 12% forced. What is that FEV1? Amount of air that can be exhaled in the first second. It should be more than 80% in healthy. If it is less, then you need to give a bronchodilator. If it is more than 12%, it indicates asthma. Worsening of FEV1 or of more than 15% after exercise is asthma. So increase in FEV1 of more than 15%, not 15%, it is 12%. AM PM variation 20%. FEV1 decreases by 15% after exercise. FEV1 by FEC will be less than 18%. So ideally speaking, an increase in FEV1 of 12% after SABA and a decrease in FEV1 of 15% after exercise should be the correct. If we change this 12 to 15 to 12, it will be correct, or if we change this 12 to 15, it will be correct. Ideally, all answers are wrong. Look at this. Increase in FEV1 after salbutamol by 12%, decrease in FEV1 by 15% after exercise. Right now we have one more method called fractional excretion of nitric oxide, in which more than 20 parts per billion indicates eosinophilic inflammation. 20 to 25, the child may respond to inhaled corticosteroid. More than 35 parts per billion, the child will respond to inhaled corticosteroids. I repeat, 12% post bronchodilator, more than 15% reduction with exercise induced bronchoconstriction. Done. History of fever with bloody diarrhea 2 weeks ago in a child, followed by swollen red erythematous knee joint. What is the most likely cause? So this is probably a case of Reiter's syndrome, post-viral arthritis, Reiter's syndrome or reactive arthritis. Reactive or post-infectious arthritis, which is nothing but sterile inflammatory reaction following a recent infection, usually lasts less than 6 weeks. It is characterized by a criteria called Berlin, which says that peripheral arthritis, usually lower limb asymmetrical oligoarthritis, evidence of preceding gastrointestinal or gastrourinary, genitourinary with Shigella, Chlamydia, Yersinia, in the absence of clinical symptoms. Here Shigella is there, so Shigella, Chlamydia, Yersinia. Exclusion of all other causes. Okay, I repeat, so it is most commonly Shigella, followed by Chlamydia, followed by Yersinia. Which one? Post-infectious arthritis. Infectious arthritis. What else we need to know? And then, so it is a triad of arthritis, uveitis, conjunctivitis. Usually it is uncommon in children, that is Reiter's syndrome. It can be associated with a cutaneous manifestation, a psoriasis-like lesion, otherwise called as keratoderma planoregica. The treatment of choice is usually non-steroidal anti-inflammatory drugs. Okay, we don't usually treat any infection, coexistent infection. One beautiful point that you need to know is your hepatitis B can cause dermatitis along with migratory polyarthritis. Very well, like resembling serum sickness. Resembling serum sickness. For this question, Shigella is the answer. Answer. A 3-month-old child. Next question. A 3-month-old boy brought to the clinic by his parents to establish care is generally healthy and no complaints. Vaccination up to date. On examination, a harsh hollow systolic murmur means pansystolic murmur. He heard left sternal edge. Left sternal edge means it is a case of VST. Echocardiography is done which reveal isolated ventricular septal defect. Which of the following is seen in this patient? Arrhythmia? No. Heart block? No. Heart block usually a manifestation of Epstein's anomaly. Respiratory alkalosis? No. Failure to thrive? The answer is yes. Your left to right shunt, I repeat, your left to right shunt can be VST, it can be asymptomatic. Because of increased pulmonary blood flow, it can produce recurrent pneumonia. So one is, I repeat, your left, so this is a case of VST. This is a case of VST. So one, it can be asymptomatic. 2, it can cause recurrent pneumonia. It can cause recurrent pneumonia because of congestion. 3, it can cause it can cause CCF from 6 weeks when the pulmonary pressure regresses, or long-standing non-treated case can lead to Eisenmenger syndrome. In this scenario, the ideal answer will be failure to thrive, particularly if it is a large VST, particularly if it is a large ventricular septal defect. So the answer for this question, it can be asymptomatic, it can cause recurrent pneumonia, it can cause CCF. CCF in turn leads to failure to thrive. So the answer for this question is failure to thrive. A 4-year-old female child presents to the physician's clinic. Her mother states that she is otherwise normal and healthy and achieving all developmental milestones. She can walk and reach objects, normal birth history. She transfers objects from one hand to other hand, which usually occurs by 6 months. What does this transfer of object implies on development? Very, very easy. It is visual motor coordination. It is visual motor coordination. What are all the other things? With respect to hand-eye coordination or hand-eye-brain coordination, hand regard, any child up to 12 to 20 weeks will bring the hands in the midline and look into it. This is called hand regard, which disappears after 20 weeks. A child can hold things ulnar grasp by 6 months, intermediate grasp by about 8 months, and radial grasp by about 10 months. And pincer grasp starts by 9 months and ends by 1 year. Object permanence, when they left something, they will try to search it. This is called object permanence. Which vitamin deficiency? Next question. Which vitamin deficiency can cause neonatal seizures? Invariably, for your level, if it is a NEET type of question, invariably you can say pyridoxine. But remember, if it is INICET AIMS, it is not only pyridoxine, neonatal seizures. It can be due to, apart from pyridoxine, you can have biotin, you can have folate deficiency, you can have biotin and thiamine, you can have folinic acid, you can have tetrahydrobiopterin, you can have riboflavin. All these vitamin deficiencies are associated with neonatal seizures. So thiamine can come, riboflavin can come. So to be very frank, B, C, D all can come. I repeat, apart from pyridoxine, biotin, folate, folinic acid, tetrahydrobiopterin, and riboflavin all deficiencies can cause neonatal seizures. A 15-day-old child brought to the emergency department with projectile vomiting, along with hypokalemia and metabolic alkalosis. Whenever you vomit everything, your hydrogen will come out from the stomach, your chloride will come out, your potassium will come out, leading to metabolic alkalosis along with hypochloremia and hypokalemia. The physician had diagnosed, the pediatrician has diagnosed congenital pyloric stenosis. Which one of the following is true about congenital pyloric stenosis? Bilious vomiting? No, it is due to pyloric stenosis. So, it is non-bilious vomiting. Right hypochondrial palpable mass? No, it is epigastrial palpable mass. I repeat, epigastric palpable mass. Metabolic alkalosis? No metabolic acidosis, no metabolic alkalosis. Hypochloremia? Yes. Hypokalemia? Yes. The answer is C. Ultrasound is the most common investigation we do. We don't do endoscopy. We don't do barium meal follow through. Ultrasound, if it shows a pylorus length of more than 16 millimeter and thickness more than 4 millimeter, invariably it is a case of congenital pyloric stenosis. The treatment of choice is Ramstead pyloromyotomy. In case if you can't do any surgery, in order to reduce the tone of sphincter, atropine can be used. Please, an MCQ, atropine can be used to reduce the tone of the sphincter. And finally, what is this? A 10-year-old child present with selective mutism. That means the child is speaking at house, not speaking in the clinic, not speaking in the park, not speaking in the school. It means the child must be having some anxiety disorder whenever it is exposed to some foreigners. So this child is suffering from anxiety disorder. Look into this. This selective mutism is more often a difficulty in social interaction and not language disorder. It is selectively not speaking at home or with parents. It is associated with anxiety. It can often lead to panic attacks. Cognition is intact. The child should be allowed to speak in social situation. Very rarely selective serotonin reuptake inhibitors are used to reduce the anxiety. A 9-year-old child diagnosed with nephrotic syndrome is presented to the outpatient department with swollen face, suppressed growth, blurred vision, difficulty in food and burning urination. He has been receiving prednisolone therapy for the past 9 weeks. What are all the most common diagnoses? So whenever your prednisolone doesn't work, you give 2 mg per kg per day for about 6 weeks. If the child doesn't respond, then it is called steroid resistant nephrotic syndrome. The most common cause for steroid resistant nephrotic syndrome is focal segmental glomerulosclerosis. For those cases, you will continue steroid and you will add calcineurin inhibitors such as cyclosporin. If cyclosporin doesn't work, do mutation studies. If mutation is positive, stop cyclosporin, plan renal replacement therapy. If mutation is negative, despite cyclosporin, you can try mycophenolate, mofetil and rituximab. Answer for this question is A. A 10-year-old child presented to the outdoor department with a burning sensation during urination, along with the dribbling of urine for years. Ectopic ureteric orifice urolithiasis is associated with colicky pain, which is not shown here. Here there is continuous dampness of her underwear and there is continuous dribbling from the beginning. Posterior urethral wall, can it be a no? She is a girl. Posterior wall, it is a disease of boys. Okay, if there is continuous dribbling of urine, probably it is an ectopic ureter. Ending in and around the bladder neck, beyond the bladder neck. Probably this is a case of ectopic ureteric orifice where you find this continuous dribbling of urine and continuous dampness of the underwear. Urolithiasis, painful colicky pain. Posterior urethral wall cannot happen. Secondary enuresis can happen, but continuous dampening or continuous dribbling of urine cannot occur in any of these cases except ectopic ureteric orifice. Very, very simple, apply logic, that's it. A 45-year-old boy presents to the clinic with complaints of fever of gradual onset, loose watery stools. So intestine is involved, cough on and off, so lung is involved, bone pain, multi-system involvement, probably connective tissue disorder or malignancy. Remember, this child has got scaly erythematous lesion with red papules on the scalp, a large spleen and lymphadenopathy. What is this? Very, 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 very simple. Whenever you have a seborrhea, involving scalp, invariably you will need to think in terms of Langerhans cell histiocytosis, for which we use more often vinblastine containing regimen. This LCH can present as isolated eosinophilic granuloma involving your vertebra. Hans color Christian triad leading on to bilateral exophthalmos, seborrheic rash and diabetes insipidus due to involvement of posterior pituitary. Or it can cause Litterer Sebi disease, which is a disseminated disease involving the lung, liver and bone along with spleen. Remember, spontaneous regression rarely occurs in LCH apart from neuroblastoma. Screening, you all know that your electron microscopy will reveal Birbeck granules, and the granules will be positive for Langerhans or 207, which is specific, whereas screening test is CD1A. Treatment, as we discussed already, vinblastine containing treatments should be given. So bilateral exophthalmos, think in terms of LCH, diabetes insipidus, lytic lesions of the skull, early eruption of teeth and chronic draining ears, seborrhea not responding to your routine treatment. A 10-year-old boy, next case, a 10-year-old boy presents to the clinic with a complaint of pain with a palpable mass at the lower end of the femur. Lower end of the femur with the pain during night, unless otherwise it is due to osteosarcoma. That's it. Any nocturnal pain anywhere is malignancy unless otherwise proved. Particularly lower end of the femur, it is osteosarcoma. It is usually occurs in adolescent. Distal end of femur or proximal end of tibia. Flat bones are less commonly affected. Most common metastasis to lungs. Most commonly it will be misinterpreted as trauma or infection. Remember, conditions such as multiple exhastosis, enchondroma, Paget's disease, previous irradiation received for some other purpose, can lead to, or your retinoblastoma, P53 Lee-Fraumeni syndrome can lead to this, predisposes to this osteosarcoma. MRI is the preferred for primary, whereas for secondary you can do PET-CT scan. Limb sparing surgery we use nowadays. Remember, unlike Ewing sarcoma, it is unresponsive to radiotherapy. Unresponsive to radiotherapy. Which one? Osteosarcoma. Next one, a 16-year-old male presents to the clinic with complaint of pain in the posterior thigh. The pain originates in the patient right buttock and radiated to the back of the knee without radicular involvement. Radicular involvement means nerve involvement. Musculoskeletal examination is within normal limit. X-ray shows onion skinning appearance. Onion skinning appearance is a feature of Ewing sarcoma. Ewing sarcoma most often involves flat bones like pelvis, vertebra or diaphysis. If it is a long bone, lung and bone metastases are common. Most common differential diagnoses are LCH and osteomyelitis. Why that onion skinning appearance? Because destructive lesions can cause diaphyseal involvement leading to multiple layers of periosteal formation. Light microscopy, very important. Small blue cell round tumor. Immunohistochemistry will be positive for vimentin and CD19. Remember, 1122 translocation is pathognomonic. Remember, it melts like an ice. Unlike your osteosarcoma, this one melts like an ice for high dose radiation. Again, amputation is very rarely required. This is all with respect to Ewing sarcoma. And finally, what is this? A 7-year-old child presented to the outdoor department with stressed and socially active mother with complaining of bedwetting 1 to 2 times. He used to go to bathroom at the age of 5 years, but after that he lose self-control. So this is secondary enuresis. Our physical examination and lab are normal. So secondary enuresis, counseling and better toilet training can be achieved. So answer will be C. Answer will be C. What do you mean by nocturnal enuresis? So whenever you have a primary enuresis, means passage of complete evacuation of bladder. I repeat, complete evacuation of bladder after 5 years at inappropriate locations twice in a month. If a child is more than 5 years, it is called enuresis, nocturnal enuresis. Primary nocturnal enuresis means the child has never been dry, whereas secondary nocturnal enuresis means the child has been dry for 6 months, now got secondary nocturnal enuresis. Monosymptomatic means the child passing enuresis only during night, whereas if there is dribbling, poor urinary stream, diurnal enuresis, then you need to rule out posterior urethral wall, spinal defects, bladder bowel dysfunction, constipation, as well as neurogenic bladder. If there is poor urinary stream, urgency, hesitancy, dribbling of urine, kindly rule out all these things rather than thinking about primary nocturnal enuresis. The treatment is usually diet advice. The rule of 6, after 6 p.m. you are not supposed to take any fluids. Fluid intake 40% in the morning, 40% in the afternoon, 20% in the evening. No coffee, no carbonated drinks after 6 p.m. Again, it is followed by, first one is diet therapy, second one is it is followed by behavioral therapy, in which you need to advise the child to go to bathroom at 10 p.m. Again, you need to wake up the child at 12 a.m. Ask her to pass urine. Dry days should be given some sort of any gift, whereas wet days should not be punished. So this is motivational therapy. So step 1 is motivational therapy. Step 1 is alarm therapy. Usually almost all these children will pass urine only at particular point in the night time. During that time, you need to put an alarm so that the child wakes up and go to bathroom, pass urine and come. Your antidiuretic hormone is very short acting. Recurrence is so common. Those can be used only as a short-term basis whenever the child wants to attend a function, marriage, speech, everything. So this is all about your enuresis. Let me share this typed question and answer in our section right now. Here the link will be provided here. And all the very best for your entrance examination. Hope this session will give an immense benefit to you. Thank you. Thanks from Dr. Sarath Balaji on behalf of PW here. Thank you.